Welcome to lecture 8. This is the second of 3 lectures on mood disorders. And today's lecture is going to focus on the etiology and treatment of unipolar depression, so mostly major depressive disorder. Last lecture, we talked about the current existing unipolar depression diagnoses, which are major depressive disorder, persistent depressive disorder, and premenstrual dysphoric disorder. We also talked about symptom clusters and symptoms of major depressive disorder. So unipolar depression is characterized by sadness and/or anhedonia, in addition to physical symptoms that relate to appetite, sleep, energy, and movement, and more mental symptoms that relate to guilt, self-loathing, self-esteem, thoughts of suicide, and concentration. We talked about how seasonal affective disorder, complicated grief, and premenstrual dysphoric disorder are mood disorders or mood symptom clusters, presentations of major depressive disorder, that have specific etiological factors and risk factors that are unique to those disorders or presentations. So for seasonal affective disorder, the unique risk factor is individual differences in responsiveness to changes in light levels, and most likely sensitivity to the effect of melatonin on mood. For premenstrual dysphoric disorder, there's a specific vulnerability to hormones related to menstruation. And with complicated grief, the trigger is bereavement, and risk factors have to do with the circumstances of the death, of the relationship to the deceased, or attachment style of the person who's grieving. The remainder of that lecture focused on the heterogeneity of depression. So as I talked about and as the guest lecturer talked about, depression has a lot of different symptom combinations, as many as 227 different combinations of 9 diagnostic symptoms. And even though these symptom combinations make for really different clinical presentations, there's limited evidence that the type of depression symptoms someone has actually makes a big difference in their prognosis, their response to treatment, or the course of their illness. What seems to matter more in predicting those outcomes are the severity of the symptoms, how chronic they are, so how long depressive episodes last, and how often they recur. So as you'll remember when we discussed etiology, about 50% of first major depressive episodes never recur. So depression is a lot more common than we've previously thought in the field and more common than your textbook says. Most likely, somewhere between 30 and 50% of people will have at least one major depressive episode, but half of those people won't go on to experience recurrent depressive episodes. Okay, so that's where we left off last time. Today, this lecture is going to focus on the etiology of depression, so where does depression come from? And we'll talk about biological, environmental, and cognitive etiological factors for depression. And then we will discuss how those factors are integrated in our current understanding of depression. And then we're having a guest lecturer today, discussing some of the interesting similarities between depression and generalized anxiety disorder that have led to many in the field to think of these two disorders as really not that different from each other, potentially as two sides of the same coin. And then lastly, we're going to discuss a little bit the treatment of unipolar depression. Most of the treatment pieces we discuss will be in the context of discussing etiology and the factors that maintain symptoms. But we'll talk about medication and cognitive behavioral therapy for depression. Okay, so we started talking about one of these 3 biological risk factors in the last lecture. So chronobiology relates to how well a person's circadian system responds to changes in the environment, and with depression, how well specifically the circadian system is able to respond to changes in light levels with winter. The dominant biological risk theory for depression, and one that actually relates closely to the other 2 in ways that we'll talk about, is the monoamine hypothesis. And then lastly, individual differences in responsiveness and reactivity to stress also might predispose people to depression in ways that potentially are mediated by the monoamine system. So as we talked about in the context of seasonal affective disorder last time, depression affects every bodily system that is mediated by the circadian cycle. So the circadian cycle refers to daily rhythms in alertness, activity level, appetite, sleepiness, and cognitive functioning, so alertness. In the context of depression, we most think about dysregulation of chronobiology in causing symptoms of insomnia or hypersomnia. What we didn't talk about last time is that although sleeping too much or sleeping not enough are both symptoms of major depressive disorder, and sleep is really closely tied to seasonal affective disorder, even in individuals who don't experience insomnia or hypersomnia, there are sleep disturbances associated with depression. So people who are depressed experience earlier onset of REM sleep. REM stands for rapid eye movement, and it's the stage of sleep where people dream. So we're not totally sure why this happens. It could have something to do with changes in the quality of sleep. So when people are sleep deprived, they tend to enter REM sleep faster. But again, this is something that happens in depression regardless of sleep-related depression symptoms. People with depression also experience shorter duration of the deep sleep phases of sleep, so stage 3 sleep. And then interestingly, and again, this isn't super well understood, but there is actually a relationship between sleep deprivation and positive mood. So in people with unipolar depression who are currently experiencing a depressive episode, depriving them of sleep for a 24-hour period can have a major impact on depression. It can actually reverse depression symptoms completely and return someone who's depressed to a euthymic state. But that change goes away as soon as the person is allowed to rest again. As we'll talk about in the next lecture when we talk about bipolar disorder and mania, in someone at risk for mania, someone with bipolar disorder, that same kind of sleep deprivation can trigger a manic episode. So, like I said, last time we talked about seasonal affective disorder, which is seasonally reoccurring major depressive disorder that's probably linked to less natural light exposure happening in the winter in areas that are north or south of the equator. So seasonal affective disorder, as again we talked about, involves what's known as atypical depression symptoms, and specifically atypical sleep disturbance. So hypersomnia, difficulty waking up in the morning. And as we also talked about last time, sleep is regulated by melatonin, which is produced as soon as the sun goes down. Melatonin production is activated by dark and suppressed by light. What we didn't talk about is that melatonin is actually the end product of the serotonin cycle. So we're going to talk a lot about serotonin and its role in depression, but it's definitely probably the neurotransmitter that most people associate with depression. But what's less known is that melatonin is a breakdown product of serotonin. So everyone kind of knows that serotonin is implicated in depression, but in this part of the lecture, we're going to talk about the ways in which serotonin interacts with mood and the ways in which serotonin helps to control and regulate mood. So first of all, even though we all kind of associate serotonin with depression, it's actually not the only neurotransmitter that is closely involved in the functions that are disturbed by mood disorders. So serotonin is what's known as a monoamine, and there are two other types of monoamine neurotransmitters in the body, norepinephrine and dopamine. And we talked a little bit about norepinephrine in the context of anxiety disorders. It's involved in the anxiety response and the fight or flight response. And it's implicated in people in the etiology of anxiety disorders for that reason. We haven't talked as much about dopamine. We'll talk about it more when we talk about substance use and binge eating disorders, because dopamine is involved in motivation. So dopamine is the neurotransmitter that underlies our experience of reward when we do something that's naturally rewarding, like eating food or having sex, or when we take a drug that is sort of artificially rewarding, like alcohol. So the monoamine system regulates every function that's altered in both depression and mania. So we know this now, but the role of the monoamine system in regulating mood was actually kind of discovered by accident in the 1950s. So basically there were sort of three simultaneous discoveries that all happened by accident that all led to the development of the monoamine hypothesis of depression. The first was that reserpine, which was a blood pressure drug that was used in like the 40s and 50s. It was discovered that some people who took this drug became depressed. And later, scientists actually learned that one of the byproducts of reserpine, one of the unintended effects, is that it depletes monoamines in the brain. So taking reserpine reduces the level of serotonin, dopamine, and norepinephrine that is available for the brain to use. So around the same time, this contraindication of reserpine was being discovered. Doctors who were treating tuberculosis patients with a new anti-tuberculosis drug sort of accidentally discovered that patients who took this drug also experienced improvements in mood, appetite, and cognition. So they began calling this drug a psychic energizer because they noticed that it improved all of these factors, and it basically improved the functioning and quality of life in these patients independently of its effect on tuberculosis. And it turned out that this class of drugs was the first monoamine oxidase inhibitor. Monoamine oxidase, as we sort of talked about early on, works by inhibiting the breakdown of monoamines in the synapse. So it means that monoamines that are naturally produced by the brain are available for signaling purposes for a longer period of time. The last piece of the puzzle was the accidental discovery of tricyclic antidepressants, which were first used as antipsychotics. Again, it was found that when patients with psychosis were given these drugs, they experienced improvements in mood, in cognition, in appetite, energy level. So that brings us to, from like the accidental discovery of these drugs, that brings us to more intentional hypothesis-driven research on these drugs that led basically to the discovery that all three of these drugs that influence mood have an impact on the monoamine system. So serotonin, dopamine, and norepinephrine. Epinephrine is a breakdown product of norepinephrine. So the role of monoamines in regulating mood was inferred from the fact that these drugs that all impact the monoamine system also impact mood. And then through a series of scientific studies using monoamine drugs as treatment for depressed patients, this theory was supported by findings that monoamine oxidase inhibitors, tricyclic antidepressants, and later selective serotonin reuptake inhibitors improved depression symptoms in at-risk patients. Interestingly, these drugs, especially SSRIs, can also trigger manic episodes in people who are vulnerable. So we'll talk more about this next time, but that also led to the discovery or sort of the development of the theory that mania is also caused by irregularities and dysregulation in the monoamine system. So starting in the 80s and 90s, science began to focus more closely on the role of serotonin above all the other monoamines in regulating mood and depression. And part of this was related to studies that found that in the brains of people who died by suicide, or in the cerebral spinal fluid of people who attempted suicide, there were significantly lower levels of serotonin. So this led to the idea that serotonin was actually correlated with severity of depression. And in 1987, the first selective serotonin reuptake inhibitor was introduced. This was Prozac. And Prozac was actually a blockbuster drug because it was as effective as monoamine oxidase inhibitors and tricyclic antidepressants, but it had a much more favorable side effect profile. So it was a lot easier for patients to tolerate, and it was easier to justify prescribing it for someone because the risks of taking it were a lot lower. And as the name indicates, SSRIs, although they do have some limited impact on reuptake of dopamine and norepinephrine, they're more specific to inhibiting the serotonin reuptake process and selectively increasing the availability of serotonin in the synapse. So I just wanted to highlight again that serotonin comes from somewhere endogenously, and all neurotransmitters are actually made out of protein, which is a structure that's made out of amino acids. And we actually get the basic building blocks for these neurotransmitters from the food that we eat, specifically from dietary proteins. So serotonin in the brain actually begins as tryptophan in the gut. So again, it's not just serotonin that is produced in the gut and that comes from food. Norepinephrine and its breakdown products are also influenced by foods that we eat, to the extent that people who are taking monoamine oxidase inhibitors can't eat certain foods that contain a lot of a protein called tryptase, because it causes rapid increases in norepinephrine that can cause cardiovascular complications. So the fact that serotonin is synthesized from tryptophan has kind of led to the popular myth that turkey makes you tired. Eating turkey on Thanksgiving makes you feel sleepy because tryptophan is synthesized into serotonin, which is ultimately broken down into melatonin. So this is a hyperlink if you're curious about reading about that myth being debunked. But basically, it's not true that turkey has particularly high levels of tryptophan, and actually things like nuts and cheeses have much higher levels. So this is the full serotonin cycle. And the important things to sort of know are that tryptophan is synthesized from breaking down dietary proteins in the gut. 5-hydroxytryptophan is the version of tryptophan that's able to cross the blood-brain barrier. So it's not that easy for chemicals that are circulating in our bloodstream to enter our brains. Only certain chemicals are able to cross the barrier that limits the blood flow into limits the ingredients in the blood that goes into our brain. So 5-hydroxytryptophan is how tryptophan gets into the brain, where it's synthesized into serotonin. And as we'll talk about in the next couple slides, serotonin has widespread impacts on mood, but also on cognition, sleep, memory, even digestion. And then lastly, the last important thing to remember is that the final breakdown product of serotonin is melatonin. And this highlights a significant overlap between the monoamine hypothesis of depression risk and the chronobiology hypothesis. Because serotonin signaling, and specifically the availability and levels of serotonin in our brain, but more complicatedly than that, how much serotonin is allowed to break down and degrade influences the regulation of our sleep cycles. So the monoamine hypothesis and the chronobiology hypothesis really aren't separate. They interact with each other because serotonin and melatonin ultimately come from the same compound. So as I said, most of the serotonin in our body is produced in the gut. The vagus nerve is one of the 10 cranial nerves that goes from the brain into the peripheral nervous system and helps control bodily functions outside of the nervous system and also bring information from the body back into the brain. The vagal nerve, or the vagus nerve, innervates the gut, so it's responsible for all of our digestive processes. It also innervates the genitals, so it's responsible for sexual functioning and sex drive. And the fact that the vagus nerve is strongly dominated by serotonin signaling helps to shed some light on the appetite and sexual consequences of depression, and also potentially the appetite, the weight gain and sexual side effects of SSRI medications. So I'm not really going to talk about this in treatment, but just an interesting novel, still being tested treatment for depression is vagus nerve stimulation, which is an implanted pacemaker under your collarbone that stimulates the vagus nerve and is thought to help bring more 5-hydroxytryptophan and serotonin into the brain from the gut. So even though, partly thanks to the popularity of serotonin reuptake inhibitor drugs, it's really not true that serotonin is the most important monoamine in regulating mood. What it does seem to do is it helps to regulate levels of the other two monoamines, norepinephrine and dopamine, which are both equally important in regulating mood, appetite, cognitive functioning, and sleep. It's just that serotonin seems to be kind of the key to maintaining balance of the other two monoamines. So it's hypothesized that having low serotonin levels doesn't make you depressed or alter your mood in and of itself. It alters your mood by allowing norepinephrine and dopamine to fluctuate more widely. Because a well-regulated monoamine system should mean that serotonin is keeping norepinephrine and dopamine signaling in check. So continuing more recently, drugs that have more affinity for norepinephrine and dopamine are becoming popular treatments for depression, popular drug treatments for depression. And especially the class of drugs that has affinity for dopamine, like bupropion or Wellbutrin, are becoming popular because they have fewer weight gain and sexual side effects than SSRIs. So these drugs just help to demonstrate that even though serotonin does seem to play a very important role in regulating mood and regulating sleep through its breakdown product melatonin, the other two monoamines are also important in regulating mood. So even though monoamines are definitely important, the fact that we can't test biologically for depression, we can't take someone's blood and look at their levels of serotonin or the balance of serotonin, dopamine, and norepinephrine, means that monoamines alone do not cause depression by themselves. So this is a great example of the stress diathesis model, where the diathesis here is dysregulated monoamine signaling. But without life stressors, without life events, that alteration in monoamine signaling and serotonin's regulatory control of dopamine and norepinephrine would not be enough to cause depression, which is why there's no biological test for depression using monoamine levels. So this figure on the right should be familiar. This is a well-known study of the effect of child abuse on risk for depression in people with the short or long allele of the serotonin transporter gene, sorry. So as we talked about in lecture 2, people with 2 short copies of the serotonin transporter gene allele are at elevated risk for depression, but only in the context of life stressors. So the original study that we talked about looked at severe child abuse and maltreatment and found that for people with 2 copies of the long transporter allele, these negative life events didn't really raise their risk of depression significantly, controlling for a lot of other variables. But for people with 2 copies of the short transporter gene allele, child abuse was a more significant risk factor for developing depression. The stressor doesn't have to be as severe or chronic as child abuse, so I wanted to include this figure to illustrate that. This is a study that looked at serotonin transporter gene polymorphism and just the number of stressful life events in general that someone was exposed to. And these stressful life events included things like a relationship breakup, being fired, losing a loved one, moving to a new place. So it was kind of a range of stressful experiences, but less chronic and less severe than child maltreatment. And you can still see an interaction where people with 2 copies of the short allele have more, they're more responsive to environmental risk. So with less environmental risk, so 2 stressful life events, they still have a higher probability of getting depression than someone with 2 copies of the long allele who has 4 or more stressful life events. So what these studies show is that one way of measuring the functioning of the serotonin system, and people with 2 copies of the short version of the serotonin transporter gene have less serotonin signaling and lower serotonin levels. So according to the permissive monoamine hypothesis, it's not necessarily just that they don't have as much serotonin signaling, but their serotonin isn't as able to balance norepinephrine and dopamine signaling. But that alone is not enough to substantially increase their risk of depression. It's only enough in the context of child abuse or a number of stressful life events. So stress and life events are really important in depression, and that kind of leads to the third biological vulnerability theory for depression, which is dysregulation of the HPA axis. And we've talked about the HPA axis before in the context of anxiety, because when someone has an acute stress response, so when they respond to an unconditioned stimulus for fear, like being chased by a dog, or when they respond to a conditioned stimulus for fear, like elevated heart rate in someone who has a history of panic attacks, the brain registers that stress and sends signals to the hypothalamus, which is a structure in the brain. The hypothalamus releases corticotropin-releasing factor, which signals in the pituitary gland, which in turn releases ACTH into the bloodstream, where eventually it reaches the adrenal cortex on the kidneys, or on top of the kidneys, and the adrenal cortex produces cortisol. When cortisol enters the bloodstream, it helps to initiate the body's stress response. But what it also does is it sends negative inhibitory feedback to the pituitary and the hypothalamus to tell them to stop producing CRF and ACTH. So the HPA axis response is meant to be acute and short-lived, and it's meant to be self-limiting. So when you have cortisol in your blood, in addition to causing the body to go into the fight or flight response, it's also telling the brain, okay, you can stop signaling with CRF. We're already having a reaction. We don't need to keep having this reaction once we've escaped from the stressor. But in people who are exposed to chronic stress, who have continually high levels of cortisol in their blood because they keep being exposed to acute stressors over time, that negative feedback function of cortisol can break down. And that happens because the receptors for cortisol on the hypothalamus and pituitary basically just get worn out and they stop working as well. So they stop letting cortisol bind as effectively, and cortisol binding doesn't inhibit the cells on the hypothalamus and pituitary that release CRF and ACTH as effectively anymore. And this leads to a condition called hypercortisolemia, which is basically just having chronically elevated cortisol levels in the blood. There is a biological test for hypercortisolemia. Mental illness is not the only thing that causes it. It's also caused by thyroid conditions, and it can be caused by medical conditions like obesity and diabetes too. But the medical test for hypercortisolemia is known as the dexamethasone suppression test, and your book describes this. Basically, dexamethasone is a glucocorticosteroid, sorry, it's a lot of syllables. But basically, it's a steroid that looks a lot like cortisol and it binds to the same receptor. So when someone has a functioning HPA axis and the receptors on their hypothalamus and pituitary are responding appropriately to corticosteroids, giving them endogenous or exogenous dexamethasone should suppress cortisol production. So even if they're subsequently stressed, their cortisol production should be lower because dexamethasone is binding to their hypothalamus and pituitary and telling them to not release CRF and ACTH. For someone who has a broken negative feedback system in their HPA axis, where cortisol binding to those structures doesn't inhibit cortisol production, the dexamethasone suppression test is failed. So dexamethasone doesn't suppress production of cortisol because the receptors for cortisol on the hypothalamus and pituitary aren't working the way that they should. So in the anxiety lectures, we talked a lot about how HPA sensitivity could be a biological predisposing factor to anxiety. If your fight or flight system goes off in response to sort of normal or less intense stressors than other people, that means that you'll be having a lot more fear and anxiety responses. But what it also means for depression is that it might take less intense or less prolonged environmental stress to cause a breakdown in the negative inhibitory feedback system. So if your HPA axis is constantly being activated and you're someone who doesn't require as much stress to activate it, you might experience hypercortisolemia sooner than someone whose HPA axis is less responsive to stress. And just like chronobiology and sleep, the HPA axis is regulated by the monoamine system. So norepinephrine is one of the 3 monoamines that's implicated in mood. Norepinephrine plays a special role in anxiety because it signals in the hypothalamus to help regulate the release of corticotropin releasing factor. So when serotonin isn't properly regulating the function of norepinephrine, one thing that can happen is that there's imbalanced norepinephrine signaling in the hypothalamus, and that leads to the HPA axis being more sensitive and more reactive to stress. So just like the chronobiology theory isn't independent of the monoamine hypothesis, neither is the inflammatory theory. Norepinephrine is one of the 3 monoamines, and norepinephrine regulates the HPA axis. Okay. So in the last lecture, we talked about how depression is associated with cognitive deficits and how people, when they're depressed, aren't as good at forming memories. This is partly because of neurotoxicity. So cortisol, when it's flowing freely in our blood, is actually really damaging to our cells, including our neurons. And cortisol seems to have the most effect in parts of our body where there's what's known as neurogenesis, which is the birth of new neurons. And the hippocampus is one area where there's a lot of neurogenesis. And that's because the hippocampus is involved in forming memories. So the hippocampus is a place in our brain where when new things happen to us, new synapses and new connections are made. So when someone is depressed and experiencing hypercortisolemia, the birth of neurons can be suppressed and existing neurons can be killed. And the hippocampus is really sensitive to that process happening. So these figures are evidence from studies in humans that actually show that there's a dose-dependent effect of depression on the size of the hippocampus. So what we're looking at here on the bottom is imaging studies, so MRIs, of people with chronic depression, right here, that's what ME stands for, and controls. And the controls are matched on things like age, gender, intelligence, all things that influence the size, the physical size of brain structures. So when someone has chronic recurrent depression, they are likely to have a smaller hippocampus than someone the same age, the same gender, with the same level of intelligence, which is evidence that having depression causes the hippocampus to shrink. Up here are people who are having their first episode of depression, and compared to controls, they don't seem to have smaller hippocampal volume. So what that suggests is, one, that over time, depression degrades the hippocampus and causes ongoing damage, and two, having a small hippocampus isn't a predisposing factor to depression. So the chronic depressed patients don't have a smaller hippocampus because they're vulnerable to depression. They have a smaller hippocampus because they've experienced depression. So there is some evidence from animal studies that chronic stress can cause shrinking in the hippocampus and it can impair neurogenesis there. There's also evidence that when chronically stressed animals are treated with SSRIs, it actually helps to restore the size of their hippocampus and helps to restore neurogenesis in that area. There's less evidence for this mechanism in humans, largely because it's just hard to do studies that are that tightly controlled on humans. But theoretically, SSRIs should have the same mechanism in people that they do in animals. And for some people, people who are prone to depression because of HPA axis dysfunction, whether that's because of chronic stress kind of breaking the negative feedback, or whether it's because of pre-existing biological vulnerabilities that make them more responsive to stress in the environment. Theoretically, these people might have depression because of negative impacts on the hippocampus, and SSRIs might help to reverse depression by promoting growth and neurogenesis in the hippocampus. And this study is also a human study with further evidence for the impact of stress on the size, the survival of neurons, and the birth of new neurons in the hippocampus. So there's a negative correlation between the number of days that someone has had untreated depression and the size of their hippocampus in an MRI. So whereas this study was comparing people with and without depression just at one time point, this study is looking at the relationship between duration of depression and hippocampal volume, and finding that the longer someone goes without depression treatment, the smaller their hippocampus becomes. And this study and others like it have kind of converged on the idea that hippocampal volume loss occurs after recurrent depressive episodes, and that you need to be depressed for at least 2 years, whether that's through recurrent episodes that last less than 2 years or one episode that lasts at least 2 years. So chronicity and recurrence, and not really severity, seem to be really important in predicting hippocampal volume loss in depression. Okay, so we just talked about the impact of chronic stress and HPA axis dysregulation on depression, and the idea that that impact happens through neurotoxicity and cell loss in the hippocampus. So it's clear that environmental stress is incredibly important in depression. Depressive episodes are often, although not always, precipitated by a clear stressor. And those stressors tend to be something like a loss, an interpersonal loss like bereavement or a breakup. They can be precipitated by a perceived failure. They can be precipitated by major life transitions, including positive ones like getting married or having a baby. but also negative life transitions. They can be preceded by more mild but ongoing interpersonal stress, like relationship problems in a marriage or friend group problems. And then lastly, depression can be precipitated by chronic stress, and that is probably the mechanism that accounts for HPA axis dysfunction in individuals with less pre-existing vulnerability to HPA axis dysfunction. So your level of biological risk, your diathesis, interacts with the intensity of the environmental stress that you experience. Someone with a lot of biological diathesis, so someone with pre-existing alterations in serotonin signaling, like 2 copies of the short transporter allele, or a really overactive HPA axis, might need less environmental stress to trigger a depressive episode. Whereas someone with fewer genetic vulnerabilities might not experience a depressive episode until they've been exposed to very intense or very chronic stress. I just want to highlight one important chronic stressor in the US, and that's poverty. So these are just maps of CDC maps of the states with the highest incidence of major depressive disorder. And these data are from between 2006 and 2008, which might seem a little bit outdated. But there's a really strong overlap, especially in the Deep South, with the experience of poverty. So states in the Deep South, especially Mississippi, Louisiana, and Alabama, are the poorest states in the country, in the United States, along with West Virginia. And these poor states also have the highest incidence and the highest prevalence of depression. So they did in 2006 and 2008, and they still do between 2016 and 2019. This is a study that looked at the number of suicide and crisis hotline calls for different problems. And again, the states in the Deep South with the largest concentration of people living in poverty are also the states that have the highest rates of depression. This research has been done at the neighborhood level too. So one study that was conducted in New York City found that people who were living in low-income neighborhoods were twice as likely to develop a first depressive episode during an 18-month period compared to people living in high-income neighborhoods. So poverty is a public health concern for reasons we'll talk about in the eating disorder lecture, and also for mental health reasons. And there's a clear and specific link between depression and poverty, probably mediated by the chronic stress that's associated with being poor. Okay, so the third risk factor that we're going to talk about before we try to bring it all together is cognitive and psychological. So this has to do with your way of thinking and your way of interpreting the world and events that happen to you. Sorry, I have to pause for 1 second. Okay, so as I was saying, we just talked about biological risk factors for depression and the way that they significantly interact with environmental stress. The 3 cognitive and psychological risk factors that we're going to talk about today are broadly categorized into negative cognitive style related to how events are happening to the person are interpreted, the impact of negative cognitive style on the likelihood of experiencing stress, especially interpersonal stress, and the one way that people with depression tend to think. So let's get started. Okay. So in an earlier lecture, we talked about the original learned helplessness study, where dogs were exposed to chronic uncontrollable stress in the form of foot shocks in a cage that they couldn't get out of and couldn't escape from the shocks. So over time, initially the dogs reacted to the shocks with anxiety and fear and efforts to escape, but over time, as they realized that they weren't going to be able to escape, they stopped trying and their behavior became apathetic. In that study, even when the dogs were later given a chance to escape, they were less likely to try. So this is the learned helplessness model of depression, that acute stress produces anxiety and fear, but when that stress is chronic and uncontrollable, over time, it produces feelings of helplessness and hopelessness, apathy, and depressed mood. So the way that this is thought to manifest in humans is through the way that we think and interpret our lives. So humans are conscious, unlike dogs, as far as we know, and one thing that means is that humans try to explain what's happening to them. We have a story that we tell ourselves to try to explain the events that happen in our lives. And attribution is a technical term for the types of causal explanations that people come up with for things that happen to them. So the way that people tend to explain why events happen the way that they do. Related to attribution and the concept of learned helplessness is the idea of schemas. So again, schemas are a technical term that refers to mental structures, so basically like mental templates for organizing ideas and knowledge and for informing our behavior and our interpretations of the world around us. So we have already talked about schemas in this class, we just haven't used that term. But schemas that are really relevant to the development of anxiety have to do with beliefs that the world is dangerous and that you don't have control over your own life. And especially schemas related to control are really important to depression too. Learned helplessness is thought to influence the formation of schemas that you don't have control. Other schemas related to learned helplessness are unlovability. So basically, no matter what I do in life, people are not going to love me the way that I want them to. People are not going to be there for me. People are going to leave me and abandon me, regardless of my efforts in the relationship. So learned helplessness in relation to other people and relationships. And then the last schema related to learned helplessness is the schema of defectiveness, which is the idea that I'm just fundamentally not good enough. And no matter how hard I try, I'm not going to be able to be better, so why bother trying? And we'll talk in a few slides about what it means for these schemas to influence and organize ideas and knowledge about the world and influence our choices and actions. But essentially, the important takeaway from this slide is that humans are always trying to organize our experiences, and we do this through attributions, so the stories that we tell ourselves about why things happen. And our attributions are really influenced by our schemas, which are our sort of deep underlying beliefs about the world, about ourselves, and about other people. So in the context of depression, there are three broad categories of attribution that are important in informing a negative or positive worldview. So the first is internal attributions, and this is when something in the environment goes wrong. People with a negative cognitive style are more likely to instinctively blame themselves. Another maladaptive type of attribution is the stable attribution, where when something goes wrong, people with this type of attribution style assume that the underlying cause of it is something that can't be changed. This type of attribution tends to ignore the context that the negative event happened in and the influence of other factors in the environment outside of the self or outside of other unchanging factors. And then lastly, whatever the perceived cause of the negative event is thought to be global, is thought to apply to other situations that may or may not actually be related. So I will give a depression-related example of this in a couple slides, but I couldn't resist this demonstration of someone making what's known as an attribution error. So incorrectly making a stable attribution about something and not taking into account the impact of the environment.
Oh my God.
Okay, so that was a stable attribution error because she was assuming that the underlying cause of an experience she had, or something in the world, in this case, was stable, that he looked small because he was small. Whereas he wanted her to make a more environmental attribution, where she took into account the context in which she was seeing him, that he had just gotten out of the pool. Okay. So in this video is another example of negative attribution styles, but in this video, the character actually demonstrates kind of 2 out of 3 negative attributions. So when you watch this again, or as you're watching this lecture now, try to think, what attributions was she making that seem negative, that seem internal, global, and stable, and what attributions seem a little bit more adaptive and balanced?
All right, meet us at the corner of Garfield and Jackson, but those streets don't intersect.
Stop doing directions, Bob. Nobody interrupt him. Lucky we ever get anywhere. It's so stupid. Oh God, my babies every day. So now.
Let's try and stay calm. So that normally say no if it gets walk around. See, those are playing.
It's all my fault. If I had gotten so caught up in my own investigation, kids wouldn't be in danger right now.
That's true.
Bob, you're not supposed to agree with me when I play myself.
All right, so then it's not your fault.
Thank you.
Okay, so we can talk about this in class, but again, she made 3 attributions and 2 of them were negative, 1 of them was more balanced. Okay, so this is a more depression relevant example of a negative attribution style in action. So again, negative attributions start with something negative happening to us, something bad happening in our lives, a negative life event. So say for this person, the negative life event is that his girlfriend gets home from class and is mad because he was home all day but didn't do the dishes. So his girlfriend being mad, this interpersonal negative life event, might activate negative schemas that he has that arose through learning and modeling in his earlier life or through chronic stress. So her being mad about his failure to do the dishes might activate his schema that he's unlovable, that people are going to leave and abandon him regardless of what he does, and the schema that he's defective, that he's just not good at doing things. So if he makes a negative attribution about her being mad and the implications of it, he might think like it's totally my fault that she's mad, which may or may not be true. She's mad because I'm so lazy and selfish. So a stable, unchanging fact about him. And this is exactly why things never work out for me in relationships, and this is why she'll eventually break up with me and leave. So this is an example of, because the schema was activated, the schema that he's unlovable and defective, he makes a negative attribution about the situation, about his girlfriend being mad. And that negative attribution might result in emotions like helplessness and self-loathing, in behaviors like not really trying to change, because if his girlfriend is going to break up with him anyway, and if it's because he sucks, because he's lazy and selfish, then why bother changing? Like nothing he does really affect that. And it might lead him to preemptively start to like emotionally withdraw from the relationship because he thinks that she's going to leave no matter what. So these are some real life examples taken from the depression subreddit. So these are people with self-identified depression talking about themselves and their lives. So the first person is saying, I'm 23, I'm a failed student with no money, no joy in life, no prospects, and no future. I'm so overwhelmed with how much of a failure I am that I can't even decide where to begin. So this person is making attributions about themselves and their lives that are internal, so they're labeling themselves a failure, and stable and global. So they have no future, no prospects, no joy. However they're feeling now, whatever bad thing happened, it extends to the whole rest of their life. This is another global attribution. So because of the time that this person has lost being depressed, they'll never be able to compete against normal people. So the negative things that have happened thus far, the depression, has global implications for the rest of their life and their ability to live in the world. And then this person is making internal attributions that they're the opposite of successful, hardworking, and dedicated. So with attributions like this, the sort of natural outcome of explaining the world to yourself this way is that you'll feel bad about yourself and about the world, and that you'll feel hopeless. And this is kind of what human learned helplessness looks like in action. So bringing us back to biology for a second, people with depression, so those last 3 examples are people with depression sort of reflecting back on their lives and on the recent past. And we know that damage to the hippocampus is linked to problems with memory retrieval. So problems with looking back into our memories and selecting the right memories for the situation that we are trying to retrieve memories for. And we know that in depression, negative attributions, attributions and not appraisals, tend to include overly general autobiographical memory. So I'm a failure, I've been depressed for such a long time, I ruin every relationship I've ever had. Those statements are based on maybe faulty memories of looking back at your past and selectively remembering the events in your past that support that negative attribution and selectively not remembering anything that might be evidence against it. So we talked about cognitive distortions in the generalized anxiety disorder lecture. These are basically just examples of how thoughts, so the way that we speak to ourselves in our heads, are congruent with our mood, with what we're experiencing. So the content or type of thoughts in someone who's depressed tends to be really closely related to their negative attribution style, because negative cognitive styles influence the way that events are perceived. So one example of this could be fortune telling, so making assumptions about the future that things will never work out. So a global, stable attribution. Saying I always get rejected, people always leave me. That's an example of an overgeneralization error in thinking. It could be an example, like the previous slide suggested, of faulty memory retrieval, where when someone is in a really negative mood state and making these negative attributions about events, they are selectively remembering evidence that supports those negative attributions and overgeneralizing from them. Some people with depression, as you saw on the Reddit slide, often call themselves failures, and this is an example of labeling, where you attach a label to yourself. It's an internal and stable attribution error, that everything bad that happened to you happened because of something about you, that you're a failure, and something that you can't change, that's just a characteristic of yours. Being a failure is considered a permanent state, rather than saying I'm someone who's experienced a lot of failure, or I'm someone who has a lot of extra struggles that make it harder for me to succeed. And then personalization is another common cognitive distortion in depression, where people tend to make internal attributions. They tend to think that everything is their fault. Okay, oops. So this is a diagram of this whole kind of model of the cognitive risk factors and maintenance factors for depression. So learned helplessness and or negative schemas about the world are formed early in life. That's the cognitive theory of depression. That's something about our upbringing, the modeling that our parents provided for us, or chronic stress and chronic negative life events led us to feel out of control, like we couldn't do anything to change the way that our lives were going, and to form negative schemas. So explanations of all the bad things that happened to us that are based in the belief that we're unlovable or defective. So when someone with these negative schemas or with a history of learned helplessness is exposed to a new stressor, so in the previous example of fight in a relationship over doing dishes, that stressor activates their schema, their learned helplessness, their belief that they can't change what happens to them because they're a failure, they're unlovable, they're defective. And when that schema is activated, because schemas are the way that we organize our ideas and knowledge, the way that we retrieve our memories, and the way that we explain what's happening to us, the way that we integrate new knowledge and new information into our minds. When those schemas are activated, we tend to make negative attributions and experience cognitive distortions or thinking errors, like personalization. It's all my fault. Labeling, I'm a failure. Overgeneralizing, I always fail. And naturally, those kinds of negative thoughts and negative attributions lead to depressed mood, and then downstream of that, behaviors that are indicative of feeling hopeless and helpless. So behaviors that don't really try, or that aren't really directed at changing the situation or improving it, because based on learned helplessness, the person believes that they really can't do anything to change the situation anyway. So just a small note here that negative attributions can sometimes be accurate. Like sometimes things are internal, sometimes things are somewhat stable or global. There's in psychology, in cognitive psychology, what's known as the Lake Wobegon effect, which is that if you ask 100 people how good at you, or sorry, if you ask 100 people how good are you at some task, like driving, on a scale of 1 to 100, where 100 is the best driver, 0 is the worst driver, and 50 is an average driver, the way that averages work is that most people should say that they're a 50, that they're an average driver. But people don't respond that way. Most people think that they themselves are a little bit above average, even if they know that most people are in the middle. So there's a phenomenon known as depressive realism, where people with depression are actually more accurate sometimes at predicting how well they'll do at simple tasks, or they're better at recognizing that they're more likely to be average because everyone is more likely to be average. People who are depressed can sometimes be more accurate judges of their own abilities. Being depressed doesn't necessarily always mean exaggeratedly thinking that you're the absolute worst. Sometimes it's recognizing that you're probably just average. So this kind of weird imbalance actually kind of suggests that maybe it's healthy to be a little bit deluded about how good you are at things, that maybe a sign of healthy cognitive functioning is to think that you're a little bit above average, even if you know intellectually that it's not true. Okay. So now we're going to get into the second psychological risk factor model for where depression comes from and what makes it. So the stress generation hypothesis is that people who are prone to depression because of their cognitive style, because of learned helplessness, schemas about being unlovable or defective, and the tendency to make negative attributions and have cognitive distortions related to that content, people with these cognitive vulnerabilities are actually more likely to encounter negative life events than people who don't have these vulnerabilities. So as an example, someone who has the belief based in a schema of defectiveness that they're a failure and that they're not going to do well academically this semester might be a little bit less motivated to study, because if you know that you're going to fail already, then why waste your time? And as a result, they might actually be more likely to get a bad grade than they would have if they had spent more time studying. Another example of this could be someone who has an unlovability schema, who thinks that they're just fundamentally unlikable and that they're not going to be able to make friends. Believing that and thinking that might lead them to avoid social opportunities or to be withdrawn and closed off in social situations. And those behaviors, rather than anything internal or stable about the person, could be what causes them to miss out on opportunities to make friends. So essentially, the stress generation hypothesis is that sometimes negative expectations turn into self-fulfilling prophecies because they influence our behavior. So in the dishes argument example, a person who makes these attributions about their girlfriend being annoyed with them, that it's all their fault, they're lazy and selfish, things are never going to work out, and they'll eventually end up breaking up, ends up feeling hopeless and self-loathing. Yeah, so it's bad for them internally, but it also influences their behavior in a relationship. They might withdraw from the relationship. They might not bother to try to make it up to their girlfriend or do something to change their behavior, make it more likely that they'll do the dishes the next time. So this will have interpersonal consequences. So if the person during this argument articulates these negative attributions and says, I'm so sorry, I'm absolutely the worst, I hate myself, I'm so lazy and selfish, I know that you are eventually going to break up with me over this, I'm so sorry, I'm terrible. What their partner is probably going to do is feel pressured to comfort that in that moment. And that can lead to resentment in the relationship because it takes away the girlfriend's ability to be mad about something that she has a right to be mad about, that you're not pulling your weight in the relationship. You making these attributions and articulating them during an argument could make the other person feel manipulated or feel like you're changing the subject, that you're taking something that's about your behavior that you could theoretically change and making it about who you are as a person, forcing them to comfort you, but also to acknowledge that if you think that you're like this as a person, you're never going to change. So a more adaptive, less stress-generating way of handling this situation might be to make attributions that are actually less internal. To say, like, I'm really sorry, I just was feeling so depressed today that I just couldn't get myself out of bed to do the dishes. I really apologize. That might seem like you're putting the blame, that you're shifting the blame, putting it on something else, but by making an attribution that's less internal, less stable, and less global, that's more specific to the situation with the dishes, that offers more opportunities to improve and to do things differently. Then your partner might be able to say, like, well, that really sucks. It's unfair that I have to do all the chores in the household. Do you think that tomorrow you could set an alarm and at least try to do one thing, or at least rinse your dishes before you put them making attributions that are less internal and less stable creates opportunities to problem solve. But making these very negative internal, global, and stable attributions can take away from that. And there's evidence that it causes a lot of stress and tension in relationships when people make these kinds of attributions. So of course, the stress generation hypothesis is not about victim blaming. People who are depressed don't typically know that they're doing this. They're not trying to manipulate their partner into shifting the focus from them not washing the dishes to their depression. They might really be looking for reassurance and comfort in that moment. They also tend to believe the negative attributions, so they're not being manipulative, but they are feeling really helpless and hopeless, and those feelings make it really hard to be proactive and make positive changes in your behavior. So that's what depression therapy is all about. It's hard to do these things on your own, but therapy is about recognizing patterns, so recognizing your negative cognitive style and actively trying to take control over those patterns to improve both how you feel and also your relationships with other people. So bringing it all home, this is sort of the integrative model of depression that we've been laying out here. So biological vulnerabilities, like for example, HPA axis sensitivity or imbalances in the monoamine system, can trigger a depressive episode only in the context of a stressful life event, like say getting fired from your job, and a negative cognitive style. So interpreting that failure, that negative life event, as internal, stable, and global, and sort of allowing it to feed into and confirm your schemas about defectiveness. That combination of 3 risk factors is what leads to a major depressive episode. Any one of those risk factors alone probably wouldn't be enough to lead to depression. Another theory that's compatible and consistent with the first is that there are some types of stressful life events that are severe enough or chronic enough to actually change biological vulnerability, so that cause HPA axis dysregulation and neurotoxicity, and also to change cognitive styles, so to induce learned helplessness or to influence our schemas. And that interaction of really severe chronic stress, even in the absence of biological risk factors that would be sufficient to trigger depression with an ordinary stressor, can lead over time to the development of a major depressive episode. So the mechanisms are the same. It involves biological risk, negative cognitive styles, and stressful life events. But the intensity of each one of those risk factors is balanced out by the intensity of the others. So someone with a lot of biological risk might not need as stressful a life event in order to experience a major depressive episode, whereas someone with really minimal biological risk could still experience a negative or a depressive episode with enough chronic stress in their lives. Okay, so before we begin to talk about treatment, I do want to highlight one more theory, which has to do with not so much the content of the thoughts of people with depression, so thoughts that tend to be negative, that tend to be internal, global, and stable attributions, but actually the way that people with depression think, so the process of their thinking. So I showed you this figure during the GAD lecture, but basically, depression and generalized anxiety disorder are disorders that are characterized by distress, by high negative affect. And whereas the other anxiety disorders that we've already talked about are more characterized by acute, but only periodic feelings of fear. So the negative affect in fear disorders is more specific than the negative affect in distress disorders. So this slide sort of summarizes all of the risk factors that we've talked about for depression. But the thing to emphasize here is that these risk factors are not specific to depression, especially the biological and general psychological risk factors. These are the same risk factors we talked about in the anxiety disorders lecture, just with a little bit more specificity. So there are a lot of biological risk factors and genetic overlaps between risk for anxiety and depression. And it seems like maybe what matters in determining whether someone will go on to develop anxiety or depression, given the same set of risk factors, has more to do with the type of proximal risk, so the type of environmental stressors or cognitive styles that they have in the context of biological and general psychological risk. So I'm going to actually show this week's guest lecture conversation in its entirety during this lecture. Dr. Krasnow is an expert on the overlap between generalized anxiety disorder and major depressive disorder, and her research is really making the effort to disentangle these two diagnoses, or to sort of demonstrate how and why they might not be able to be disentangled.
So depression and generalized anxiety disorder, or GAD, have a lot in common and are really highly comorbid. And so most people who have depression also have GAD, and then a very large proportion of people who have GAD also have depression. And the two disorders are highly linked because both of them are considered distress disorders. And so people who have them have like really high levels of overall distress. There are certain things that like connect the two disorders that are similar versus different. And so the feature of both depression and GAD that is similar is how much they involve repetitive perseverative thinking. So an important feature of depression is rumination, which is thinking about things that happened in the past over and over again in like a kind of broken record type way of like what happened, how it could have gone differently, like what why people are like messed up or did things the wrong way or something like that. People with depression experience a lot of rumination, and rumination is really closely linked to worry, which is the main feature of GAD. So GAD is characterized by uncontrollable and excessive worry about multiple areas in life. And worry and rumination are like basically the same thing. The only difference is that rumination focuses on stuff that happened in the past, whereas worry is about something that might happen in the future. So ruminative thought could be something like, I did so poorly on that test. Like, what did I get wrong? Like, how did I go wrong? What could I have done differently? Whereas a worry might be, how am I going to do on the test tomorrow? Like, how can I study well enough? And that distinction has been made, but honestly, the two overlap so much that it's like pretty hard to tell them apart. And so that's the feature that connects depression and anxiety the most. Yeah, so there are aspects of rumination that could, in theory, like work well for you, right? And so the reason that we all think about past things that we did is because we're trying to figure out in a way like what happened and how we might do it differently in the future. And so it's related, but different from problem solving. And so kind of both are the different sides of the same coin. So rumination is sort of the less adaptive version of problem solving. Like I'm sure a lot of us have like thought about problems and like sort of carry them around in our heads, like over a few weeks, sort of like thinking about it and thinking how we might sort of fix the situation, and then the thought kind of pops into your head and you're able to move forward and get unstuck. And so that's the same like thought process that happens in rumination. It's just that we never really get to the problem solving part of it. And so it's kind of like problem solving gone wrong. So there are these two different aspects of emotions that we have. So one is like the negative feelings that we experience. So things like distress, feeling upset, feeling like shameful or guilty or overwhelmed, like all of those kind of negative emotions. And then we also experience positive emotions, and they're not only opposites of each other. So you can experience positive and negative emotions like at the same time or at different times, and just because you're experiencing one doesn't mean you're not experiencing the other. The positive emotions are things like pride and excitement and satisfaction and things like that. So a lot of the disorders that you're learning about this semester have a lot of negative emotions that come along with them. So, you know, particularly depression, when you're in a depressed mood, you feel like sad and hopeless and upset and helpless, and all of those things. And that's actually common across all of the emotional disorders. So it happens in depression, but it also happens in anxiety, right? Feelings of like of irritability and anxiety, those are all kind of negative emotions. Feelings of you know, sort of like heightened kind of like worry or those sorts of things. And so so having higher levels of negative affect or those negative emotions ties all of those disorders together. But depression is particularly characterized by having low levels of positive emotions. So actually one of the two core symptoms of depression is what's called anhedonia, or not experiencing interest or pleasure in things. And so that describes like the kind of the feeling of like maybe emptiness or lack of motivation or sort of low energy that people with depression feel. And that is mostly unique to depression. And so when you ask people about how many positive emotions they're experiencing, it tends to be that people who are feeling more depressed feel less positive emotions. And that's not necessarily the case with people who are feeling anxious or have anxiety disorders.
Okay. Okay, so to summarize that video a little bit, there are a lot of similarities between depression and generalized anxiety disorder. They're both characterized by a lot of negative emotion, not just anxiety, which is elevated in people with depression too, but guilt and shame and low self-worth, which are elevated in people with generalized anxiety disorder. Both depression and GAD are characterized by persistent depressing thoughts that worsen mood. So in the GAD, you actually talked about how the act of worrying makes people with GAD more anxious and makes them feel worse. Depression and anxiety, especially GAD, also share the same cognitive general risk factors, beliefs about control and danger, and they also share a lot of overlapping biological risk factors too, to the extent that, as Dr. Kazanov said, most people who meet criteria for depression also meet criteria for GAD. There are some important differences, though, that help us tell these two disorders apart. One of the key differences that Dr. Kazanov just talked about is positive emotion. So depression is really defined by a lack of positive emotion, either because sadness is so pervasive that it sort of takes up all the space and prevents someone from feeling positive, or because of anhedonia, which blunts all emotional experiences, including positive emotion. Another key difference is the focus of the perseverative, repetitive thoughts. In anxiety, generalized anxiety disorder, worry is focused on the future, whereas in depression, rumination tends to be focused on the past. However, just like we talked about worry serving people with generalized anxiety disorder thinking that worry serves a purpose, that worry helps them problem solve, rumination is also problem solving gone wrong. Rumination in and of itself isn't necessarily a negative or a bad thing, just like worry isn't necessarily a negative or a bad thing under the right circumstances. But when someone is depressed, the tendency to ruminate interacts with their negative cognitive style and their negative mood to mean that they're thinking repetitively and perseveratively about failures and losses that they've experienced in the past. And that in their problem-solving process, as they're ruminating and trying to figure out what went wrong, they're sort of incorrectly or overgeneralizingly identifying causes for their problems that are internal, stable, and global. So ruminating when you are depressed actually maintains the depression by narrowing your focus and causing you to spend a lot of time thinking about negative content and making negative attributions. So that also tends to reinforce learned helplessness and negative schemas, because the only evidence you're thinking about is evidence that those things are true. Just like worrying in GAD, people who are depressed tend to ruminate a lot about their depression, just like people with GAD engage in meta-worry and worry about the implications of their worry. So in the depression lecture, I showed a couple slides showing people engaging in rumination about being depressed. One of the problems that people with depression are sort of consistently trying to solve by ruminating is the problem of being depressed. But again, because of their negative cognitive style and their mood state associated with depression, this problem solving related to depression tends to be focused on negative things. So you might start thinking like, okay, why am I so sad? I don't really have a good reason to be sad, so I need to just snap out of it. But then you start to think about all the reasons that you do have to be sad, everything that's ever gone wrong for you, even if the causes of those negative events weren't the same as the causes of whatever's happening right now, or even if they're not relevant to your life right now. So even though people with depression might think that rumination is an effective coping strategy, that it's a good way of solving their problems, because of the other factors involved in depression, the negative mood and the negative cognitive style, rumination just tends to make things worse. Okay, so let's briefly talk about depression treatment. We already talked about the medications that are effective for depression. So in order of what's most commonly used today, it would probably be selective serotonin reuptake inhibitors like Prozac and Zoloft, selective norepinephrine and dopamine reuptake inhibitors like Effexor and Wellbutrin, and then less commonly prescribed because, as I said, they have some negative side effects and contraindications with other drugs and with other foods, are monoamine oxidase inhibitors and tricyclic antidepressants. And again, because those have less specificity for reuptake and they have less specificity for serotonin, they can cause cardiac problems because of their effects on norepinephrine throughout the body, not just in the brain, where serotonin reuptake inhibitors act. So the two types of treatment I'm going to focus on in the next couple slides, and we are getting towards the end, are electroconvulsive therapy, which is a last resort treatment for really severe and resistant depression, and psychotherapy.
In 1982, a young nurse was suffering from severe, unrelenting depression. She couldn't work, socialize, or even concentrate well enough to read the newspaper. One treatment changed everything. After 2 courses of electroconvulsive therapy, or ECT, her symptoms lifted. She went back to work, then on to graduate school, where she earned high grades. At first, she talked openly about her life-changing treatment. But as she realized many people had an extremely negative impression of ECT, she stopped sharing her experience. ECT carried a deep stigma, left over from a history that bears little resemblance to the modern procedure. The therapy was first used in medicine in 1938. In its early years, doctors administered a strong electrical current to the brain, causing a whole body seizure, during which patients might bite their tongues or even break bones. Modern ECT is very different. While a patient is under general anesthesia, electrodes deliver a series of mild electrical pulses to the brain. This causes huge numbers of neurons to fire in unison, a brief, controlled seizure. A muscle relaxant keeps spasms from spreading to the rest of the body. The only physical indication of the electricity flooding the brain is a twitching foot. The treatment lasts for about a minute, and most patients are able to resume normal activities about an hour after each session. ECT is commonly used to treat severe cases of major depression or bipolar disorder in patients who haven't responded to other therapies or who have had adverse reactions to medication. Half or more of those who undergo treatment experience an improvement in their symptoms. Most patients treated with ECT have 2 or 3 sessions per week for several weeks. Some begin to notice an improvement in their symptoms after just 1 session, while others take longer to respond. Patients often continue less frequent treatments for several months to a year, and some need occasional maintenance sessions for the rest of their lives. Modern ECT is much safer than it used to be, but patients can still experience side effects. They may feel achy, fatigued, or nauseated right after treatment. Some have trouble remembering what happened right before a session, for example, what they had for dinner the previous evening. Rarely, they might have trouble remembering up to weeks and months before. For most patients, this memory loss does improve over time. What's fascinating is that despite its proven track record, we still don't know exactly why ECT works. Neurons in the brain communicate via electrical signals, which influence our brain chemistry, contributing to mood and behavior. The flood of electrical activity sparked by ECT alters that chemistry. For example, ECT triggers the release of certain neurotransmitters, molecules that help carry signals between neurons and influence mental health. ECT also stimulates the flow of hormones that may help reduce symptoms of depression. Interestingly, ECT maintenance works better when paired with medication, even in patients who were resistant to medication before. As we come to a better understanding of the brain, we'll likely be able to make ECT even more effective. In 1995, more than a decade after her first course of ECT, the nurse decided to publish an account of her experience. Because of the stigma surrounding the treatment, she worried that doing so might negatively impact her personal and professional life. But she knew ECT could make a difference for patients when all else failed. Though misperceptions about ECT persist, accounts like hers have helped make doctors and patients alike aware of the treatment's life-changing potential.
Okay, so that was a little bit of a refresher on what electroconvulsive therapy is. We talked about it in the first lecture as a sort of biological treatment for psychopathology. This is a person's perspective on what getting ECT is actually like for depression.
So for me, I had tried a bunch of different medications already for my depression, and I had tried therapy as well, and nothing really seemed to be working. So my doctor suggested that we try electroconvulsive therapy. So I think the first thing that people don't really know about it is it's not just a one-time treatment. So for me, I went and had it done 12 times, so 3 times a week for 4 weeks. So I was pretty scared initially, not really knowing what exactly it was going to entail and what exactly ECT was, or what it was going to feel like, or what it was going to do in terms of side effects to me. But I went, and so it usually happened first thing in the morning, and there was always a group of us. So there was a mix of some inpatients and some outpatients. I was being treated as an outpatient when I received it. So there was a group of us that went in to get it done at the same time, basically. So outwardly, I was showing that I was calm and, I guess, composed about the whole situation, which is why they usually put me near the end of the group, which was a little bit problematic because then I could hear and see some of the other people getting the treatment done, which was a little bit traumatic to say the least. So basically what would happen would be that they would set you up with an IV, and then they would attach an electrode to your temple, either on one side or on both sides, depending on which kind of ECT you were receiving. I only had it on the one side, but then they would hook that up, and then going through the line, they would wheel you over to the station where they do the ECT, and they would inject you with a muscle relaxant in order to relax your muscles so that you didn't break any bones, or so that you weren't really sore the next day after having the seizure. And then they would put you under with general anesthetic. So they would kind of explain that process to you, and then they would count backwards from 10 as they put the general anesthetic into you, and you would lose consciousness. But because I was near the end of the line, I was still conscious while others were getting their ECT done, so I could hear the seizures and I could kind of see what was going on with the doctors and whatnot. So that was a little bit traumatic, but it helped to kind of understand the process a little bit better as well. So when it was my turn the first time, it was really scary because there was doctors and nurses standing over me, and I had an electrode attached to my temple, and I knew that I was going to be shocked in order to induce a seizure. So the actual treatment was done while I was put under. And so while I was unconscious, they administered the small electric currents into my temple to pass through my brain, and that's when I had the induced seizure, which is what they believe helps to alleviate some mental health symptoms. So the seizure, the aim of the seizure is to be around anywhere between 30 to 60 seconds. From what I saw and what they told me, it was anywhere between really 20 to 60 seconds. So just to reiterate, you are unconscious during this process and you don't feel any of the electricity passing through you or the seizure or anything like that. And you don't remember it either when you wake up. But basically when I woke up, I was a little disoriented because of being put out and shocked. But I was able to remember where I was and what had happened and whatnot with a little help from the nurses and a little prompting from the nurses. I had a headache and I was sore already. But other than that, it went okay, I think. So it took about an hour to come out of the anesthetic, and I wasn't allowed to drive myself home, obviously, for obvious reasons. As the day progressed, after I got my first treatment, the headache got a bit worse, and I got quite a bit more sore as well, just from the effects of being tense during the seizure. I told the nurses this the next time, and they gave me a little bit more of the muscle relaxant, which did help. And I just took some ibuprofen for the headache. So recovery time after the procedure, they recommended taking the whole day off, but I oftentimes would just shower to get the gel out of my hair from the electrodes and go to school. I probably wouldn't recommend doing this. I'd probably recommend taking a day to just kind of relax and recuperate, but I think it affects everybody a little bit differently. So a lot of people say that it's kind of a gradual lifting of the fog for them when they receive ECT and it's effective. So this is why I kept going back for more treatments, even though it didn't really seem to be helping me at the time. Unfortunately, after the whole course of the ECT treatments, I didn't really feel any effects, and I was really left with memory deficits as well. So it really affected my short-term memory, and to this day, I still have some problems with short-term memory. So because it wasn't effective for me, some people have asked me if I regret getting it, and the simple answer to that is no, I don't, because I was in such a point with my depression at the time and early signs of schizophrenia that I was so desperate for reprieve or desperate for any form of effective treatment that I was willing to really try anything. So no, I don't regret doing it. I wish it had worked, but it didn't. It is a treatment that works for a lot of people, and there are quite a few studies coming out lately that indicate the effectiveness of the treatment. So if you're watching this and thinking about getting ECT, or your doctor has mentioned it to you as a possibility, I just want you to know that it's not as bad as people commonly think it is, and it is effective for some people.
So I let that play all the way through, just because I mostly wanted you to see it as just to get a sense of what the process is actually like for someone going through it. But she does mention that it wasn't effective for her because, well, at the time she was showing really severe symptoms of depression, but also early psychosis. We're actually going to hear more from her. She's a blogger, a mental health blogger, who talks a lot about her experience with schizophrenia. So we'll hear more from her in the psychosis lecture. But as we'll talk about then, one possible reason why ECT might not have been as effective for her or at all effective for her is that some symptoms of early psychosis can really mimic symptoms of depression, but it is thought to have slightly overlapping but mostly different mechanisms. Also, memory deficits could be tied to the electroconvulsive therapy, but memory deficits are also a symptom of schizophrenia. Okay.
Exactly it is.
So to summarize both of those slides before we talk a little bit more about psychotherapy, ECT is thought to work by helping to rebalance and regulate the monoamine system. But as both videos emphasize, we really don't know specifically why it works. That's not the only reason why it's a treatment of last resort. It's also, it has a lot of side effects. It's very time consuming. But before doing something where we don't really understand the mechanism of action, we choose therapies first that actually target the mechanism. So the SSRIs specifically target the monoamine system, which is implicated in depression. And cognitive behavioral therapy specifically targets negative thinking styles and maladaptive thinking to try to alleviate mood symptoms. So what we know about CBT is that on average, in general, for most people, it's as effective as selective serotonin reuptake inhibitors in the short term. There's some evidence that once both treatments are stopped, so once CBT is over and once someone goes off antidepressant drugs, CBT is better at preventing relapse than antidepressants. But an important thing to remember is that when depression is more severe, when it's more chronic and recurrent, and when the symptoms are more severe, it seems that the combination of CBT and selective serotonin reuptake inhibitors works better than antidepressant medications alone. And as I think we may have talked about with anxiety disorders and medications, SSRIs may have an impact on neurogenesis, but they might fail to permanently correct other mechanisms of biological risk for depression. Whereas CBT is meant to be a long-lasting change in the way that people think, the schemas that they have to explain the world, and their cognitive style and attributions about things that happen to them. So CBT is intended to be something that lasts longer beyond the acute phase of treatment. Okay, so this is the last video, and this is like one of the last slides, but I want to show you this because this is Aaron Beck, who basically is the inventor of cognitive behavioral therapy and the whole cognitive behavioral model to explain not just depression, but most of psychopathology. So he's a very big deal in the field. And here he is kind of explaining how CBT therapists try to intervene on people's negative attributional styles in therapy. So it's a little long and he might be a little hard to understand. He's actually still doing public speaking. He's like 97 years old. But I will sort of review and run through the video after it's over.
So, for example, one of my patients came in and he said, "Doctor, I'm so depressed, I think I want to kill myself." And I said, "Why is that?" And he says, "But this is a total failure." And I said, "What way are you a total failure?" And he said, "Well, failure as a husband, as a parent, as a business person, as a homekeeper, as a home supporter, and so on." So I could have, at that level, just talked about the sense of helplessness, failure, but I wanted to get more information. So instead of addressing helplessness, which seems to be across the board there, or the sense of failure, or the sense of frustration, I started taking each of these components in order, keeping in mind that the overall meaning of what he said did have to do with failure, right? It's pretty clear that his belief, well, I am a failure, he just grabbed hold of them, and now it's playing out in every aspect of his life. So I asked, well, first of all, he said you're a failure as a husband. So what's happened recently that gave you that thought? He said, well, my wife went off to work today. She didn't say goodbye. And I said, well, so what does that mean to you? And she says, well, it means she doesn't love me. I said, why is that? I said, because she always says goodbye, but now she must be ticked off and she doesn't love me. And somehow, I don't know what, but there's something about me that turns her on. So I said, okay. So then I kept going on. So I said, now what makes you think that you're a failure as a father? And he said, well, because the kids are all fighting this morning. So I said, okay. And I said, what makes you think that you're a failure as a businessman, a provider? I said, because I just looked at the budget report and we're going to go in debt for the next 3 months. And then finally, I said, well, what about your failure as a homekeeper? And he said, well, the roof is caving in the house. So here, could have just dealt with the common denominator. The meaning is he's a failure. Each of these things we could have talked about the failure. But then I broke it up into each compartment. And this is what he went have done as a psychoanalyst. Psychoanalysts would look for unconscious meaning, or might be for the conscious meaning. But we break this up into the different pieces. So I then asked him, what about your wife running off? I said, do you remember of anything that happened prior to her running off? And said, well, she was very rushed at breakfast. And I said, do you remember any conversation that you had? And he said, well, I guess she told me she had a very important meeting coming up. And I said, oh. And what else did she say? She said she was late for the meeting. I said, oh, well, is it possible that the reason she rushed off without saying goodbye was that she was in a hurry? He said, that does make sense. So then I asked him, what about you teenagers fighting all the time? And he said, yeah, it's terrible. I just can't seem to control them. And I said, well, what about the other kids in the neighborhood? Are they all very quiet? They all get along with. And he said, yeah, I guess teenagers do fight. And then I asked him, what about the business? He says, well, we're going to run a deficit next year, next semester. And I said, but you're in the clothing business. I understand you run through cycles. And you run through the cycle where you're making more money than you're spending, and then you run through another cycle where you're spending more money, you manufacture the dresses, and then you make up for it the next trimester when you start selling the dress. You say, yeah, I guess you're right. So then I said, well, what about the roof caving in? And he says, well, the roof was leaking. And I said, yes. And he says, well, it's caving in. So I said, well, what do people do when the roof is leaking? And he said, no. I said, well, what did you do in the past when you had problems with the roof? He said, oh, I called the roofer. So I said, no. Isn't that a job for the roofer? And he said, yeah, you might be right.
Okay. So I think one thing that video demonstrates is the types of negative attributions that people with depression make. So these are not major chronic life stressors. These are sort of ordinary day-to-day things, kind of like the earlier example of someone's partner being mad at them for not washing the dishes. So what Tim Beck was demonstrating, Aaron Beck, his name is Aaron Timothy Beck, and I'm never sure which one to call him because he goes by both. But what Aaron Beck was talking about was cognitive restriction. So what CBT therapists do with patients is help them start to challenge the logic behind their negative thinking and to try to replace some of their thinking errors and their negative attributions with more balanced thoughts that don't lead to the same results, that don't lead to as much sadness, depression, and hopelessness. So what played out with this patient that he's describing to the therapist in an early session was he thinks that his wife is going to leave him and doesn't love him anymore because she left without saying goodbye. So the negative life event was his wife being abrupt and leaving without saying goodbye. This person, because of cognitive vulnerability to depression, might have a history of learned helplessness and negative schemas, like in this case, that he's unlovable, that ultimately people will eventually leave him. So it's natural to think that because his wife left without saying goodbye, that's evidence that that scheme is true. So he engaged in some thinking errors here, including mind reading, that he was just inferring or assuming that because she left without saying goodbye, she didn't love him. Catastrophizing, so he went from she is mad at me to she doesn't love me to she's going to leave me. Those were three big jumps, all based on mind reading, the assumption that she was even mad in the first place. And personalization, so interpreting her behavior to mean something about him. So based on those thinking errors, he came to the negative attribution that his wife doesn't love him anymore. And this is a global, well, not a stable attribution. Rather than thinking she's mad at me, which was his initial thought, he went to a more stable attribution, something that's less likely to change, that she doesn't love him. And as a result, he was feeling suicidal, sad, depressed, hopeless, discouraged. So what Tim Beck demonstrated he would do in therapy is to start to challenge the initial thought that my wife doesn't love me, the negative attribution. Start to push back on it and start to ask the patient questions that would help them generate some alternate ideas. So he asked, okay, so what else was going on this morning? Well, she was in a hurry. Why was she in a hurry? Because she was running late to a meeting at work. So the patient was selectively thinking about her behavior that would be evidence for his belief that she doesn't love him anymore, for his negative schema that he's unlovable, and for his negative attribution. But he was sort of selectively ignoring evidence to the contrary, evidence that maybe her behavior had nothing to do with him. It had to do with factors that were not stable and not global. So however she was feeling this morning doesn't have any bearing on how she feels in the rest of the relationship. So that's what a therapist would do in session. But therapy is not just about going to your therapist and having them solve your problems and make you feel better. What it's really about is helping the patient to realize that they're thinking in this way and that it's incorrect, that it's not helpful. So the next time it happens, the next time something activates that schema that he's unlovable, he recognizes that his first thoughts are likely to be thinking errors and that his negative attribution might not be accurate. So he knows for himself to go back and do that same process of challenging the negative attribution and trying to find evidence that might help to break it down and make it feel less likely and less true. With hopefully the end result that he either feels less sad and discouraged in that moment because he's able to come up with a different attribution, and ultimately that process of challenging his initial attribution actually helps him to start to correct his schema by incorporating new evidence that doesn't support the schema. So my wife was mad at me this morning, but when she came home from work, she was really loving and supportive. So maybe her behavior being rushed and abrupt doesn't always mean that she's mad, or maybe her being mad doesn't always mean that she doesn't love me. So by allowing himself to recognize and incorporate this evidence that doesn't support his schema, he's actually weakening the schema that he's unlovable. Okay, so some takeaways from this lecture. Last lecture we talked about how complicated and heterogeneous depression is, and today we talked about lots of different interacting and overlapping biological and cognitive and environmental risk factors for depression. So the main takeaways from this are that we do know that there's biological risk for depression. It seems to centrally involve the monoamine system, and the monoamine system interacts with other systems like the circadian clock and the HPA axis that help to regulate our daily rhythms and functions for the circadian clock and our response to stress for the HPA axis. In addition to biological risk factors, people have risky cognitive styles, either because of learned helplessness in their past, experiences of uncontrollable negative stress, or maladaptive schemas, beliefs that no matter what they do, at their core, they're unlovable or defective. In general, the more biological and cognitive risk someone has for depression, the less stress is needed to trigger a depressive episode. And chronic stress, especially stress related to things like poverty or childhood adversity, domestic violence, child abuse, and neglect, increases both biological and cognitive risk for depression. So chronic stress can sometimes trigger a depressive episode, or it can create the situation, the biological and cognitive risk that leads someone to fall into a depression with a relatively minor stressor. So the best treatments for depression are ones that target both the biological basis and work to try to change thinking patterns long term, to challenge the underlying learned helplessness and negative schemas that lead to negative attributions, which lead people to seeing the world in a pessimistic, hopeless way. Okay, that is that. I will see you guys in class on Tuesday.